Yes, good afternoon. And Dr. Yaffe's off at other meetings, so I'm doing the numbers and comments today. So we're into Monday of another 2-week period, as I talked about, and so we're having some test results from over the weekend. Of course, always have the weekend effect, and we'll talk about that. And more, what do we mean with the numbers, and how does that fit with our overall directions and trends and patterns that we need to look at that we've been talking about. And I hope to comment on that after I give the numbers. So, as you know, over the weekend, when we last spoke to you on Saturday, we were dealing with a large number, 511 that day. But then Sunday, when we didn't have it, it went down to 434. And today we're at 370. And as I said before, okay, that sounds positive. It sounds like a good direction. And I would say just that, because the numbers keep going up and down depending on the reporting and different issues. So I'll talk about that in a moment. But let's get the rest of the numbers through. So that means we have a total of 17,923 confirmed cases of COVID-19 since the beginning of this, back in January. In that, the distribution of male and female, about the same as it's always been, and 44% of the cases are 60 and over, which means 56 are below that. That is. And the Greater Toronto Area has about 60% of the cases that we are noting in our testing. The number of healthcare workers has a total positive since the beginning of January, 2,761. That's the cumulative number at that time. We continue to see lots of people recovering. We're now over 12,505 people. That's 70%. And that's really good news. So a lot of the people are recovering and the cases are resolved. So with that, how many people are in the hospital? So we have 984. That's a decrease from 26 yesterday, but yesterday was an increase of 33. So you can see it sort of balances out. That's why daily numbers are maybe of interest, but it doesn't give you an idea of how the overall picture is going. As I said, we'll comment about that. The number of people in the ICU, 225, down 7. The ICU, in the ICU on ventilator, up 1. Again, little numbers moving back and forth, and the overall total staying about the same, so we're more in a plateau effect there at this time. The deaths tragically continue to accrue in our COVID-19. So we had 84 more deaths since the last report on Saturday night or yesterday, and that gives us a total of 1,300 since the start of our outbreak back in the end of January. In our long-term care homes, from their data, they have now an increase of 5 outbreaks, up to 175. There are some that have resolved in there, nearly 35. We have 972 deaths, unfortunately, and that's an increase of 18 in relation to long-term care as compared to the total I gave you from the epidemiological data in IFAS. And we have now accrued over the time 3 deaths in the long-term care among staff, unfortunately, and we have talked about those in the last few days in that regard. So these are still substantive, and we continue to work to keep that plateauing, if not coming down, as best we can with the work of the IMS group, under Dr. Kevin Smith, as well as with working with hospital, Canadian Forces, and other groups going in to assist in various hospitals with different long-term care facilities at different times to fill in the gaps they need to give the ongoing response, the IPAC methods put in place, as well as assisting staff shortages due to the outbreaks to make sure that the residents are not left unattended and are given as much care as possible during this stressful time. Our retirement homes, there are 66 homes that have reported an outbreak, and they have a little balance between staff and residents in that regard there, about 11 or 12 total, and they have had some deaths still reported among residents. In that, and the data still has to be reconciled because a lot of people from the retirement homes end up getting transferred to hospital if they're quite ill because it's not really a care center at the same level in that amount. Testing. Done well over 340,000, 342,000 that is. And in the last 24 hours, we did 14,555. That's down from our high on the weekend of 17,000. But on the weekend, that was testing the results that came in on the Thursday and the Friday. Today, the number is the ones that came on Saturday on the weekend, so things are down a bit. We'll have to see how it reflects more on Tuesday because, remember, the ones tomorrow we're going to talk about are the ones that came in on Sunday. So it's always a bit of a delay of 24 to 48 hours. We still have 6,265 pending. That's down from our numbers before of 12,000 and 9,000, but that just shows you the flow of the tests that came in over the weekend period. Meanwhile, lots of testing is being undertaken throughout the province and all the long-term care homes, both of staff and residents, and that's just not the ones that were in the red category or outbreak modality, but all the homes are undergoing that testing at this time, so we're going to expect a lot more test results in the week ahead as we go forward. So, so with that, what I was trying to say, as we look at this week here, we're looking at, well, the daily numbers, and you've been sort of hearing our discussion with the media representatives about how the number means this but not that, and delay and things. The daily numbers, while of interest, don't really tell us of what's the most important things. What are the trends and directions? We've been talking about the trend and what is the community cases in there and getting that divided from the long-term care numbers. If you take our 370, we know in general about 45% of those are long-term care. That means 55% of that is probably community. We don't know that yet until about 6 or 7 days from now, actually for this day. But that's the trend and direction. So that seemed maybe encouraging. But remember, 370 before we went down. The next day we're up to 400 and 500 again. So it has this type of gradual curve coming down. What is the trend? That's what you want to know, and we want to know as far as looking at our public health measures and trends on positivity rates, because our test positivity rate continues to come down from highs of 12 to 10 to 9 to 5 and 4 and 4.2. So it keeps coming down. That's a good indication of what's happening in there. We're doing more and more testing, but getting less and less people positive. So that's an aspect there. So these trends and directions are in fact more informative than the day-to-day numbers, and we're hoping to be able to bring that more to your attention in the future and to give you an idea of, like a report card, how are we doing, much like the weather, what's the average temperature as compared to today or tomorrow, in that where we have 20 degrees yesterday and we may get, I hear, a high of 3 degrees on Thursday, so that's a bit surprising, but that's not the average. The trend is quite different in that direction. So that's the overall aspect there. Still lots of discussion at our federal levels on different components around, I would say, an equality of all the steps of public health measures and rolling back. How would we do our own frameworks on a national level? How are we the same? How are we different? Looking at a national testing, how is that supposed to look? So there's a lot of comparisons at that level, and how are each of us in our jurisdictions doing in that. So busy times, looking on different components there. And so that's the general update today, and I'm going to hand over for questions from the media.
Okay, we'll move to the phone lines.
Your first question comes from John McGrath with TVO. Please go ahead.
Hi, Doctor. The Journal de Montréal over the weekend reported that Health Canada is restricting the use of machines by Spartan Bioscience in terms of testing, citing poor performance. Is that your understanding as well? Have those machines been restricted in Ontario?
The machines, Spartan is the company that supplies both Ontario and Canada. So we understand there are some concerns at the National Medical Laboratory on some of the performance aspects related to the Spartan technology. So that's under review at this time by Health Canada. And because they have that kind of quality testing, we're going to have to wait to be informed of their opinion on that technology at this time as they work to, if there's any issues and concerns, to rectify that with the company. So we've been asked to watch for that, and we are going to be informed by their ongoing investigation.
Follow-up?
How much does any one company's methods or technology affect the longer-term plan to expand testing in Ontario? You and Dr. Yaffe have repeatedly said that you're looking forward to new methods of testing and how that will expand the capacity to test more and more broadly. Is this a setback?
Any one product is another solution. One has to have a variety of tools to go to, like we did with our current laboratory testing when we started off with only 1,000 tests a day. Now we're up to 20,000 by expanding the number of laboratories, and we can continue to expand that potential because then you're using a variety of different piece of equipment, a variety of different reagents, some of the same type of swabs in that sense there. So you're not with a sort of like a security thing. If there's a shortage in one, you can do more in the other and back and forth. So I think it's that adaptability that's necessary, and we understand from our people, the experts in there, we can keep expanding our technology there, as well as there's other technologies coming in that you hear of with serological testing that the National Microbiological Laboratory is checking into, and that we have a new national committee looking at immunity task force, and that's another one just announced at the federal level. So that's another group looking at a different type of technology. So not one technology to depend upon. Each one adds potentially resources to us, but I don't think we should be dependent on any single one.
Question.
Your next question comes from Colin DeMello with CTV News. Please go ahead.
I would love to work for TV, I was just saying. But I just had a question about the downward trend. So how many more days of this type of downward trend before you can actually say we have this under control?
Well, you remember all along we've been talking about when do we get back to where we were when we had containment and not community spread. And as I said, that was early in March, back in the first few days when we had gone up to, we thought were large numbers at that time, 60, 70, 80 new cases a day in the community. We had very few, zero in fact, in our long-term care facilities in that. So we've got to get well below our 200 in community level, way down almost to 100 or so in there. We have ramped up some more aspects in containment, so can we deal with more than that number? It's going to be one metric to look at, so that's one trend. We have to look at the so-called transmission rate, and that's another one we're looking at. We have to look at the test positivity rate coming down. So there's a number of metrics that our public health measures table is using to give a composite report that we would give up to the minister and on to the cabinet and the premier to make a decision when to move to the next phase and when the recommendation would fit that. So it's not based on one single metric. It's a composite that says, how is the transmission in the community going? Is it down to a low enough rate that, one, any things that flare up, because there will be, we can control and contain from the general public, but in the general public's attitude, what is the level of safety and confidence in that they can then engage in wider activities to the satisfaction of the public health measures table and the guidelines, but also for the confidence of the public to participate in various activities that their family and their loved ones would partake in as they restart the whole situation here in Ontario.
Follow-up?
Okay, so using all of those metrics then, how close would you say that we are to the finish line? I mean, you could use it in yards, percentage, whatever you want to use, but how close are we to that goal based on where we are today and all of the composite metrics that you see?
Well, remember a week ago when we got down to about 380, something like that, I said we're on a good direction. Then we bounced back up to 500. And I was asking the question, like, why did we go back up again? And there's blips and stuff. What does it show us in there? So we've just come down, as I said, just recently we were at 511 on Saturday. We've gone 434, 370. And I would like that to keep going down. No, it could bounce up to 400. I don't want to go back up to 500 or 600. I'd like to see it steadily going down. We wanted 2 weeks of coming down. So we're on another run of just 3 days coming down. So we'd like to see that progress and continue to happen. So we're in the range of the possible, but we're not in the range of probable at this stage. But all things are in the hopper, and we could see that if it continues to come down fairly stringently, I would be very pleased with that, but we got to see that happen.
Next question.
Your next question comes from Mike Crawley with CBC News. Please go ahead.
Hi, Dr. Williams. I want to ask you about contact tracing because, it's one of the key benchmarks that the government set around phasing out the restrictions is that ability to trace 90% of contacts of each new case within 24 hours of having a positive test. So I'm wondering if you can give me a sense of how far away Ontario is from being able to hit that target. Can you describe maybe what the capacity is right now? what percentage of contacts are being traced within that 24-hour time period, or maybe you have a sense of how long it will be before the province has the contact tracing capacity that it's going to need to hit that target?
So I think in the contact tracing, and I think there's a lot of sometimes misunderstandings of it. I'm trying to get the right comparison here. And we can actually register a case for the lab test, and we have the name of the person, their phone number, address, in 24 hours. That's not case contact management. It's like, if I can make a comparison, and I'm not talking about, I'm just using a close comparison. If you're talking like police investigation, they will get the report. How soon do they have the report logged in the station? Fairly quickly. And if you ask them, have you completed an investigation? They'd say, no. And sometimes it's day 2, 3, or 4, 5 days. They contact this person, this person, this person. So the case contact management, one is to register that you have the case, then all the investigation, going to ask people questions. Because I know you've asked me about it. If these people are still coming back positive, where did they get it from? If you ask them what they did 1 day ago, 4 days ago, 5 days ago, it takes a while for that recall. You have to ask them 2 or 3 times. And sometimes you find from someone else that there was an actual gathering. The person said, yeah, I forgot I was at that. I guess we shouldn't have been at that. I don't think it was any problem. I said, well, a person was positive at that event 4 or 5 days ago. I didn't know that. And so this kind of case contact investigation, if you may, is one thing to register it, another thing to contact the people initially, then to complete the whole investigation. Because just by saying you got names and you have no idea where they got it from, you can't do any containment. Because if they got it from a gathering, those other 10 people at that gathering could have also got it. You have to follow them up. And then if they got that person who brought it, where did he or she get it from? So you can see how it can escalate out, or you can be satisfied we've got it contained in this. And so one aspect is saying, can you register every positive case in 24 hours? That means it's on the books. That starts the investigation. But the thoroughness of the investigation gives evidence by the fact you've contained and you know all the epidemiological link cases in there, and you have them in isolation, you're managing, and you have it cordoned off so the public writ large are not impacted by a small cluster or a large cluster. You've handled it. So does that give you an idea of what it means a bit differently?
No, I understand what it means. I just was trying to get a sense of when Ontario can hit that target that was set by the government.
Right. We can put the 90% register right off the bat, because we can do that. We're going to move towards that fairly quickly to note them in our data books. But that's just the start of the investigation.
Next question.
Well, on a slightly different topic. So we've heard from a nurse in long-term care who says her facility's first resident case happened because residents were allowed to go back and forth to outside medical appointments. This is in around mid-March. Wondering if you feel now that the province could have done more to prevent that kind of thing from happening at long-term care homes and allow the spread of COVID-19?
It's a interesting assertion. I don't know what you mean, because generally if there's a doctor in charge of the long-term care facility, and before we had outbreaks in it, if they're having some health issue that's potentially could decompensate their health beyond what is expected, that doctor may order tests that can't be found in the facility. They have to go out and get the test done. So by not sending the person out, then the doctor is being less than vigilant in their care and services. By sending out, you assumed it was from your setting to another one where there was no cases there, but that doctor needs those test results back if they're going to alter the care and treatment, because the person is in long-term care, and they want to make sure that any remedial type conditions are dealt with properly. So if that happened, that would be not planned on, but sometimes they had to do that because they do not have the testing capacity within the long-term care facility.
Next question.
Your next question comes from Laura Stone with the Globe and Mail. Please go ahead.
Hi, Dr. Williams. I'm just wondering, regarding the hospital teams going into long-term care facilities, it's my understanding that about 13 out of 40 homes in the red zone, the high priority category, have not yet received that. Do you know why that is and when those homes can expect extra help?
The red designation depends on a number of. It's a rating depending on not that they have outbreaks or cases yet. Some are red even without outbreaks because they may have limited, sometimes staffing situations, limited personal protective equipment supply, limited knowledge and preparation around infection prevention control practices. So by going in and dealing with those ones there without bringing extra hospital staff in, you can move them from red to yellow and potentially up to green. So it's a movement that's shifting reds, even as we speak, over to yellow and some going up to green as they get more and more prepared. They may still have an outbreak case, unfortunately, if it does happen, and that can compromise the situation so that I know our IMS group is looking at that, where if there needs to be more staffing of a particular level come in to help, like the Canadian Armed Forces or other groups, you're trying to help an HHR issue, either a PP issue or an infection prevention control issue or other things that are necessary to stabilize that situation and to bring that outbreak under control as quick as you can with minimalizing mortality especially and morbidity as soon as possible. So just because you're red doesn't mean you have to have hospital people in right away. It may be that they're going through the train and knowledge base and then stepping up to the next level. But even a yellow one can flip over quickly if it's an outbreak, and sometimes some large green ones too. It depends on how the COVID gets into the institution.
Follow up?
Okay, and just to follow up with Mike's question regarding contact tracing, if you're suggesting that Ontario is there, we're at the stage where we could do where local public health officials could reach people within one day, could complete contact tracing within a day. So why is it necessary, as the Premier said today, for a national contact strategy? What would that achieve?
So, nationally, we all want to have the case contact management, and across the country, we do very much the same type of thing. We have different IT systems and data recording systems and some of the approaches, but the method of the investigation we use in the epidemiology, the various methods of asking questions and doing testing further on that is part of the overall caveat and approach for case contact management. To have the tests, the positive tests given to various public health people to put into the database to say we now have the person, we contact them, said we're going to be calling you in the future and that kind of stuff. As you can imagine, those initial contacts by putting those data in could be done fairly quickly, but the full package of the contact management and containment is the challenging one, much like a comprehensive, if you may, a full police investigation of a situation like they're dealing with varies from case to case and situation. So in that sense, if we do that consistently across the country, because one of the challenges we have is that are we going to start opening up where we have inter-provincial travel again, domestic flights, etc. And other problems want to know, do you have things in control in Ontario? We'd like to know, do you have things in control in Manitoba, PI, BC? And that's what the national wants to know, saying we can now encourage that kind of pan-Canadian movement. That would be an important thing to know, but that depends. Each of us has to give a sense that we have it contained in our respective jurisdictions, as an example.
Next question.
Your next question comes from Rob Ferguson with the Toronto Star. Please go ahead.
Hi, Doctor. Just to follow up on that contact tracing, I'm trying to put it in the context of that daily stat we get that says, I forget exactly what the number was today, but it's usually around 35 or 37% cases we still don't know where they got the infection. So what does that number need to get down to mean that you can have more confidence that the contact tracing is being done quickly?
Ideally, it should be at zero, because you should know where everybody got it from. How easy that is, especially now with all the big numbers in there, we have to get that supposedly through our social distancing, physical distancing. You should not be exposed. So therefore that number, as we're watching, keeps coming down. If it gets to a certain level, then you're going to ask someone saying, in your last especially 5 to 7 days of the incubation period, or in 10 days, were you in a situation where you were in contact with people in a closer range, say 2 or 3 feet or whatever, for a period of time? And people should be able to recall that, whether it was by choice or they got forced into a situation with a crowd. You can ask that question. So right now, when we ask a lot of people, we used to ask about travel history. Have you been in contact with a case? And they go, I didn't travel. I don't know of any case. But we couldn't say before, were you in a situation where you're in close contact with people closer than 6 feet for a period of time? Before, that was always the case because we didn't have those measures in place. Now we have those in place, we could ask that question and try and get down to that. Once we have that in place and that number down, we should know that your travel history, which is unlikely, mostly, contact of the case, that we do want to know, and we can actually, through our case contact manager, saying, we understand you're in a group with so-and-so, that person has now been proven a positive case, so you're exposed. Were you within the 6 feet or in closer for a period of time? So we can do that as far as our exposure history. And then we have to go back and say, in that group, there's others who are in that close group. We have to find all those as well. Because you say, not only should it's for your information, but your friends are at that one. We should know who they were because they could be incubating right now. And they need to know. So you're not putting them at risk. And so that's part of, as we hope to get down to a reasonable number. But if you're dealing with 200 to 300 new cases a day, especially think it's a certain large percent, like that's Toronto, for example, if you get 50, 60 new cases a day, every day for 14 days, all the contact tracing, that takes a lot of work. We need to get that number down to where we start to contain it in that regard. So that's the ballpark I'm talking at. So that number, I'd like to see that 35 down to ideally under 1 to 2 or 3%, because there's always some people, I can't remember what happened.
Follow up?
Okay, yes, and just to follow a bit where Laura left off about the national contract tracing plan that the Premier was talking about today. So would this have to be a significant initiative where they find some way to link up every, have the same system across the country that everyone is using? Is that what the goal is here? Just so that, as you said, we can check on people coming from Manitoba, they can check on people coming from Ontario, that sort of thing.
So what I was saying is that right now we don't have a lot of inter-provincial travel, a little bit. And from the national level, they just say, across the country, are we in a containment mode, yes or no? Because we have to be assured that each of us is saying, in our province, we know who it is, and we're told them, you can't travel next 14 days until you're clear. And so you should not be going to Saskatchewan. and they want to know that. I may say, we got someone came over, and within 3 days coming from province X, they're positive. Here's their name and information. We send it back to that chief medical officer of health and their public health people, and they said, okay, we'll follow up on that, and they'll do the investigation. We've always done that. That's for any infectious disease. We notify each other because you're transferring personal health information between health information custodian to health information custodian, still protecting the privacy, but enabling the proper investigation to keep it in a containment mode at a provincial level and at a national level.
Next question.
Your next question comes from Natasha McDonald with Radio Canada. Please go ahead.
Hi, Doctor. There's growing evidence of the possibility COVID-19 can be spread via airborne particles. Minister Fullerton said today that the province takes its advice from you about whether healthcare workers should wear surgical or N95 masks. Do you think there's the possibility of airborne transmission? And if so, why not take extra precautions to keep healthcare workers safe by allowing them the choice of wearing those masks?
So we hear such reports. We have to review them because they're not all peer-reviewed. We continue to vet it through our scientists, both in Public Health Ontario as well as at the national level. And so far, our data and on the international one, we have not had very strong assertive evidence that it is airborne. We've had some studies talk about the enhanced aerosolized type of movement and certain humidity and certain high particulate air situations, but not true airborne in the way we know it and we define it. So, no, I haven't heard any studies that have, in my mind, or our scientists' mind, convinced us that it has moved to an airborne one. We have seen some that talked about with our aerosolizing generating medical procedures, and other things that could enhance that, if you may, to go beyond a little bit of a distance there in that regard there. So we continue to be aware of that. But I think the idea of around the type of protection, we have tried to give that provision, especially because if you may be in a situation in your setting where you may all of a sudden get involved in a aerosolizing procedure, or you feel at risk of that, the healthcare worker can ask for the N95 protection in their setting in that regard there, because we're talking about the hospitals and acute care situations where you're around patients on ventilators and various equipment. So that has always been there, and it's on a risk situation, the so-called PCRA, in that regard. So we continue to be looking for the evidence, but as yet the one around the Airborne has not been substantiated.
Quick follow-up.
On another topic, I'm wondering about the integrated laboratory system. So in Quebec, for instance, hospital labs were allowed to process their own results quite early. I guess I'm asking, do you think this integration should have been done earlier? Are we and should we be using community labs to full capacity? And would it have helped the province ramp up testing faster?
We started using the hospital labs way back, and adding to that was our first wave out. When we got the testing confirmed and ensured with NML that our testing here in Ontario was didn't have to be probable. Remember those days of probable and had to be confirmed? So we moved out of that level into there, and then we started adding hospital labs. We had a whole big committee form up. Then we had a consulting firm. There's a whole network group. We've added community labs and more. So we've moved fairly I would say assertively in that direction to increase our capacity up to the 20,000 now, and with some potential even going higher in that regard. So we do have a network, and that network requires a lot of things and tools and machinery to make it all work, to maintain quality, sensitivity, specificity, so that your tests you can depend upon, and you can move that around depending on the various supply issues and that and management. So it is a comprehensive network. It's complicated, but it works well and has increased, and they're continuing to work at it as I speak and to look at further enhancements on the way forward. So we started hospital labs fairly soon way back, and we continue to expand with a variety of our lab networks that are out there now.
Okay, we're going to move to our last caller.
Your final question comes from Allison Jones with the Canadian Press. Please go ahead.
Hi, Dr. William. Today, the Premier was asked if we were going to start widespread community testing, which a lot of experts have said is key for a reopening strategy. He said that he had that conversation with the health table today, and it is being started. Are you able to give us any more details about that?
So when you talk about our testing, a lot of the provinces start off with testing very ill patients with signs or symptoms, the triad of the fever, shortness of breath, and general myalgia aches and body aches and that. That was the original one, and with high-risk groups in those settings in there that have signs and symptoms. We then expanded our definition in the last while two ways. One, we said we would ask that people have even wider symptoms with even other ones indicative of moderate or severe COVID-19 infections. Then we expanded even further, asking our assessment centers to say, would you test people who have even very mild, such as runny nose, things like that, or it could be like seasonal allergies, etc. And so they've expanded out to do those. A lot of those, of course, are members of the public and community at large who normally would not go and get tested, but they are testing on that perspective. So how many of those are like community-wide testing? They're not coming in by any plan to pick just the healthy people. They're planning on different people who come forward with the need to get tested in that. At the same time, we also expanded in the fact that we said long-term care homes. We said first with outbreak, then we expanded the definition of outbreak, then we expanded the testing to say not just the person who's symptomatic or the ones around they're symptomatic, we're going to start testing asymptomatic people around the case. Then we moved even further, saying now we're going to test not the symptomatic person around the case, asymptomatic as well. We're going to test the whole institution in an outbreak, staff and all residents. And then we went even further in saying what we'll do is right now we're going to test all the long-term care facilities, all the staff and residents, even though half of them throughout Ontario, some parts that haven't had cases in a long time, and some that haven't never had any outbreak or cases in their homes, we're doing them. That's going to be about 40,000 people who basically are members of the public who have not been exposed through travel, known contact, or outbreak. So in a way, we're doing that, and then we'll continue to do that and ramp up some more. So in a sense, we're already starting to do some of that testing because we can't plan and book it ahead of time. The people come in on a random basis in there. We've asked some of our experts to say, well, if you did a survey, how would you do it? And let's say sometimes also you can do that, and they might give us some direction to say, okay, if you have some capacity now, maybe you could look at this group. And then the other debate on the other side, that's why we have this task force at the national level, maybe you should switch to doing serial surveys of the public writ large to see what was the level of infection, what's the level of immunity. So that task force is going to come forward and look at that as we wait for a quality serological test to come in that regard. So testing means testing one line, testing other lines, who you test, and the broad base in that. So as compared to other provinces, because we get asked that, why is Ontario testing so many people who are asymptomatic? That's part of our study to look at what is the potential risk out in the population, that are we missing it? And the more bigger the numbers, the larger the numbers tested, helps our statisticians, our modelers to look at that and to get a better idea of the projections and numbers. So we're starting down there. We'll be continuing informed by our experts on who else we should test to give a general population perspective in that regard. And, of course, looking at these national bodies who might give a direction on what's a national testing strategy that would be consistent across the country, not only in our current PCR testing, but if we did go to a serological survey.
Okay, follow-up, and this is the last question.
Yes, could you just explain why we might be seeing, in general, a lot of positive numbers today, low number of new cases and a low growth rate, falling hospitalizations? Then the numbers of new deaths reported are quite high. Is that just sort of a delayed effect? Why would we be seeing that?
Okay, so you asked a whole bunch altogether there. So we're seeing, I said the 370 is just today. We're hopeful, but let's not get carried away. We're still in probably the low fours, and a good 45% of that is long-term care, and we're doing some more in there. Our case to high rate of positivity in long-term care homes peaked a few days ago, we hope. And because it takes now 7 to 10 days to incubate and people's health to be impacted, some of those people infected will not show severe disease and unfortunately sometimes death until a number of days after. So the peak of the death cases would follow 7 to 10 days or 12 days after the other one in there, because you're dealing with a broad spectrum. So we're hoping, it'll be our hope, that the deaths, the number each day, would plateau and start to come down as well as we complete that part of the curve. So there's that delay between when you get infected to when you start getting symptoms and when you get more severe cases. And makes it like we do in the general public. It's a bit more different with long-term care residents, but in there we know from a public one, if you, in the case, was 6% hospitalization, 3% in ICU, and then so many of those on a ventilator, and the success rates on ventilation depends on different data points, but that prolongs it out 2 or 3 weeks later after it, so you don't see those impacts until later on. So it's all part of letting this wave of aspects go through in that, so there are delays between cases, severity, hospitalization, and death in that result.
Okay, thank you, everyone.